I'm Dr. Oliver Stovin. I was a GP in Oundle from 1988 to 2015. At that point I retired and took on 1 day a week as joint cancer lead for Cambridge and Peterborough CCG. I was jointly employed by Macmillan and the CCG, and the job description was to improve cancer care within Cambridge and Peterborough, and also included innovation and research. I'd always had an interest in the interface between primary and secondary care and had been active within PCTs and CCGs, particularly in roles in relation to referrals and prescribing, most of which involved work with primary and secondary care. When I was asked to contribute to this, and the titles were Risk, Care and Cancer, I took it to mean in respect of the research that I've been involved with, which mainly has been cytosponge and Grail. So to me, risk was more about the risk of delivering the research both in a timely manner and in the way that was planned. The care was about the care that was given to the patients and the subjects that were participating in the trial, and the cancer was the fact that it was looking at cancer-related research. When it comes to risk, I was interested personally in the engagement with primary care and the recruitment of patients. And I think the biggest risk is actually not delivering and lack of engagement. So even before COVID, most practices are not involved with research, although quite a few do get involved with drug trials and other research projects, but they do this mainly for income. So in a lot of the projects I was involved, you're wanting much wider engagement from other practices. So it's always been incredibly important to make sure that the workload or remuneration is adequate to get interest from practices. COVID has meant that anything that increases workload is a complete no-no. So I was involved with implementing cytosponge into a primary care setting just as COVID hit, and we had to completely abandon the research idea. And certainly for the foreseeable future, anything that increases workload, whether it just be in talking to patients, is an incredibly high risk. Patient recruitment within primary care is potentially quite labour intensive, and in order to get it to work, all of the projects I've been involved with have minimised this. The other risk is, to me, that's come apparent from the research I've been involved with, is that all of these projects have to be delivered in a timely manner, in a way that primary care can accept, and anything that risks delays always has the potential to have a very negative impact and prevent delivery, as GPs will decide to do something, but if it doesn't happen, they tend to very quickly lose interest. When it comes to patient care, I've been aware that in particularly the Grail study, it was apparent that at the start of the study they really hadn't sorted out how to look after patients, but also how to support GPs in looking after patients and how to support secondary care. So Grail is about a blood test that suggests that you may have an occult cancer, and clearly recruiting a patient who just has a blood test and is then out of the blue told that they have a 50-50 chance of having cancer needs very good and appropriate care, but also the other professionals involved with them need support to make sure that they also give the care. And it's interesting how little this was considered, but has thankfully been sorted out. I was well aware a friend of mine who was involved in a COVID trial was offered antibody testing as part of a trial. They'd had both vaccines, had a blood test for antibodies, and much to their surprise was found not to have any antibodies. When they approached the trial team to find out what they should do, I was very disappointed to find out that the advice was talk to your GP, and it seemed incredibly poor care from the trial to leave this person in the lurch. And actually the issues with respect to antibodies post-COVID vaccination are incredibly complex and probably beyond the knowledge of many GPs anyway. So the other thing that I thought was worth mentioning was the cancer side of it. One thing that people may or may not be aware of is that my impression is that for GPs, cancer both has a very high priority and a very low priority. High priority because no GP wants to miss a cancer, but because of the 2-week wait system, if you have any worrying symptoms, you can actually refer patients on very quickly and effectively pass the buck to secondary care to sort them out as to having cancer or not. So GPs actually have the potential for very slick referrals when needed. Low priority because actually as a part of their workload, cancers represent a very low element of workload, and therefore there is this sort of conflict between high and low priority. And if you talk about, so for cytosponge esophageal cancer, again, this is something, although nationally has a very poor outlook and low numbers, from a GP point of view, it's something that happens every 5 years or more, and therefore a low priority. So those are my thoughts in relation to what I was asked to consider. Thank you.